Thank you for the opportunity to be here again and for this topic that we have been studying for many time. We have treated increasingly complex lesions, even those with occluded stents, and lesions like this where we had an occluded kissing stent and an occluded aortobifemoral bypass, and we were the same able to recanalize the native artery and the stents, obtaining a very nice result. And we are supported in this end-of-first strategy even by guidelines, both from US and Europe. The point is the type of reconstruction. We have heard everything this morning. There is still a debate about the best choice of reconstruction and the best material. The problem analyzing this data is mainly that the lesions that are treated are often different one from the other. There are stenosis, occlusion, shorter and longer lesions, so it's not so easy to give an answer to the question. What we know is that from the hemodynamic point of view, kissing stents and cherub have more or less the same way of acting. Cherub has a higher thrombogenic value compared to the kissing stent configuration. We have seen this slide before. From the very beginning, the cover stent had the palma. They worked better than bare metal stent. But this is true only in presence of calcification, because you can see that in absence of calcification, bare metal stent and cover stent work more or less in the same way at 3 years. The cherub, we have here two strong supporters of the technique. Work very well. There is some need for reintervention even for this type of reconstruction, 15% in this UK study, multi-center. And of course, it's not probably the best option in cases like the one on the right, because you have problems of embolization, and for sure you need the chimney to treat this patient with the cherub technique. If we compare kissing stents, open surgery, and cherub, the primary patency is better for cherub and open surgery compared with kissing stent. But if we go to secondary patency, then the results are more or less the same at 1 and 2 years. Results little better for the graft, but again, these patients are probably different because we need at least one adequate iliac access for the main body of the graft. And considering gender, then in the long run, after revascularization, the results are more or less the same. At the beginning, in the first 30 days, we have a higher risk of acute thrombosis in women and a higher risk of amputation in men. And if we go to the late result at 5 years, again, a cover stent work better than bare metal stent, and patency is strictly related to older age, active smoking, external iliac artery involvement with need for stenting, but cover stent have a higher risk of acute thrombosis at the beginning, and there is no difference in terms of primary assisted and secondary patency. So the results are not far one from the other. And again, here a large review with the primary and secondary patency. Primary patency is certainly better for cherub technique and open surgery, but secondary patency at 5 years is more or less the same. We heard that the results of this ongoing trial, they speak about the 95% at 5 years for cherub, so the results are really very close to that of open surgery. Our experience consists of 33 very complex lesions, occlusion up to the renal, all treated with kissing stents, mainly bare metal stent, selective cover stent in specific situation. The results are very good in the immediate, but very good even during time, because we have a primary patency around 5 years that is 84%, and secondary patency that is around 97%, really, I think, really good. And our results are supported even by other authors in literature. This is another authors that have results similar to ours, and is similar even in patients that are young. And so probably we can use this technique even in young patients. So in conclusion, recanalization is almost always feasible with low morbidity and mortality. The best stent configuration for each patient offer excellent immediate and late result, follow-up mandatory to ensure good secondary patency. So would you really choose open surgery for yourself? Thank you.